Super excited to bring this webinar to you all today. It's our first webinar in a series on educational issues pertaining to cardiac conditions. We're very, very lucky to have Dr. Robert Beto and Dr. Linton Frazier here with us today. I'll get into their bios in a moment, but this webinar today is entitled Mars versus Venus, Understanding Sex-Specific Symptoms of Heart Attacks. And we're diving into this critically important issue that has widespread relevance. Many of you that are attending likely know that heart attacks are the #1 killer globally among men and women. And there's no slowing down. And despite advancements such as stents and cholesterol-lowering medications, heart attack continues to lead deaths worldwide. Early detection is critical to guide an appropriate response and improve survival rates and outcomes. But there's challenges that persist in determining if individuals are having heart attacks because they represent and present so differently, sometimes among men and women, sometimes from men to men, and diabetics experience different symptoms due to a whole host of reasons, and we're going to discuss that with Dr. Frazier and Dr. Beto today. The variability can delay seeking treatment, which can be a matter of life or death. Then you add the complexities and the nuances of ECG and consumer wearables. It introduces a tremendous opportunity for people to take ownership and take control of their own heart health, but there's some complexities with determining what's the right technology based on your condition, which ones produce medical grade results for physicians to interpret. And so we're going to try to dispel some of those myths about the nuances, educate the audience about the different types of wearables and ECG equipment for testing your heart. It's certainly not the only way to test for a heart attack, but it seems to be the gold standard and the one that physicians most often trust when trying to diagnose a patient with a cardiac issue or a rhythm abnormality. So as I mentioned, we're here today with Dr. Robert Beto and Dr. Linton Frazier. Dr. Linton Frazier is a distinguished cardiologist known for her research in cardiovascular medicine and her dedication to advancing heart health since she became a physician more than a decade ago. She earned her medical degree at Penn State and currently practices at Indiana Regional Medical Center in Indiana, Pennsylvania. And she's not only a respected authority in her field, but she's incredibly passionate about patient care and education. Dr. Robert Beto joins us today he's been recognized for years for his exceptional contributions to interventional cardiology and heart disease management. He has a rich background in clinical practice and research. Dr. Beto has been instrumental in developing advanced treatment protocols that have significantly improved patient outcomes. He graduated from West Virginia University Medical School, and he's dedicated his career to exploring the complexities of the human heart, earning him numerous accolades in the medical community. He's not only committed to his patients, but he's also mentoring the next generation of cardiologists, ensuring a legacy of excellence in clinical care. And he's also the founder and CEO of Heart Nexus that provides peer-to-peer consultations for physicians all over the U.S. on heart-related issues. So we're going to start with you, Dr. Frazier, and I'll pose this question to you, and we'll bounce back and forth a little bit between you and Dr. Beto on some of these topics. So the first is, if I could ask you to sort of help educate the audience a little bit, the complexities of diagnosing men and women with heart disease, or particularly heart attack. There's a lot of information out there about the differences and the nuances. And I'm just wondering if there's any scientific reason or backing behind why that would be the case. Why would a woman experience different symptoms compared to a man?
Thank you, Jason. And before I get into that answer, let me just say how privileged and honored that I was asked to be a part of this webinar. So good afternoon or good morning to all those who are joining us. So To dispel the myth that women and men have such drastic differences when it comes to symptoms of heart attack, that's something that's been in the internet, and a myth that certainly has been perpetuated. All comers, men and women, do experience chest discomfort, chest pain. That is your classic symptoms or symptom of a heart attack. However, there are biological and physiological differences between men and women, such that women may experience what we would call the non-traditional symptoms. So for women, we'll get jaw pain, neck pain, or even pain between the shoulder blades. Women more often than men will experience fatigue, shortness of breath, and sweating. So, because of the differences in gender, there have been studies in the past that showed that there are scientific and biological differences. So, the biggest one is that men and women have different size hearts. Women hearts are smaller, their vasculature are narrower, so the arteries are narrower, such that progression of coronary disease varies. Men will have more cholesterol buildup in the larger arteries. When my colleague Dr. Bito will expand more on that, if you're looking at angiography or a heart catheterization, you'll see more blockages, more cholesterol buildup in larger arteries compared to women who their arteries are affected, the smaller arteries are affected. So that's what's called the microvasculature. One of the biggest differences, though, and this is scientifically right, men, women, the gender differences for women, the reproductive system plays a big role. So with that, there are differences in our hormones. So estrogen tends to be protective. So we find that when we're looking at postmenopausal women, they're at a higher risk for having coronary disease because they no longer have that protective effect from estrogen. When we look at childbearing women, we find that sometimes the pregnant woman can be affected by pregnancy-induced hypertension or preeclampsia or even gestational diabetes. And both hypertension and diabetes, again, we'll get to that further in the webinar. Those are two big risk factors for coronary disease.
Excellent. Thank you so much for that. That clears up a lot in my mind. And I'm just going to elaborate a little bit, Dr. Bito. You've treated many patients in the cath lab, men and women, for years, and stents and balloons and lytics, et cetera. And you've probably seen the gamut, seen complex interventions. But before they get to the cath lab, they got to hit the ER. And so, based on what Dr. Linton Fraser stated here, the nuances between men and women, with sort of the commonality being chest discomfort. How do people know when to go to the ER? How do you know if it's the right time?
That's a great, again, I like to echo Dr. Fraser's thanks and asking us to come and talk about this such important topic. So, I teach my fellows and my medical students, this is a high stakes game. It's not treating a sprained wrist. This is a high stakes game. So you need answers, you need accurate answers, and you need answers fast. Always, if there's any concern, you need checked out. We're in an age where, sometimes there's a means to get checked out with a press of a button or dial up of a doctor on a screen, right? But the workup for heart attack is very specific. It includes blood work. It includes 12-lead electrocardiograms and a physical exam by the doctor. And just a doctor or an experienced person eyeballing somebody to get kind of a gestalt on, what's going on with this person. We know that there's certain, like Dr. Fraser was alluding to, there's certain risk groups that are higher risk. A male with hypertension, diabetes, high cholesterol, whose dad died at 55, your antennas are really going to be up on him versus a 28-year-old menstruating female with a normal estrogen status, a normal cholesterol, and normal blood pressure. So, we risk, I'm sure Dr. Fraser is the same way. As soon as she sees a patient, we automatically start risk stratifying people in our minds. But if there's ever a concern, we recommend getting evaluated because this is a high stakes game. It's a high stakes situation. You
Yeah.
know the old saying, it's as serious as a heart attack, right? So that continues to hold true.
Yeah. No laughing matter there. So I'm going to bounce around a little bit. I've got a list of questions here, but just based on those responses, I'm going to go back to you, Dr. Fraser, and you have a particular specialty, electrophysiology, that specializes in the heart's electrical system and the diagnosis of abnormal heartbeats and arrhythmias. And so that may you may be at home and not necessarily feel the chest pressure, but you sort of tell you there's something not quite right, whether that be palpitations or butterflies. Is it something you ate? And so, love your opinion. If you're not having that crushing chest pain, and heavy discomfort, but you feel like you got a racing heart or you're sweating, or what would you say about when the time is right to go to the ER or call 911?
Right. Thanks for that question because that's so important. And it's so different when we talk about symptoms in isolation, right? We have to specifically relate it to the person, right? If it's a 20-something-year-old, like Dr. Beta said, 20, menstruating woman or even man that have these palpitations. Um, if the symptoms are not limiting your daily activities or it's not limiting your functional status, then I would say, well, call your primary care provider, and then, see if you can come in for an evaluation, get checked out, put a monitor on. If there are symptoms that is interfering with your quality of life immediately, if you can't walk across the room without getting quite winded or having discomfort, feeling like you're going to pass out, that's the time that you should go and seek attention at your nearest emergency room. If I have a 60, 70 something year old patient who I know have structurally abnormal heart, they've had an MI, or they are known to have coronary disease and are experiencing these symptoms, long-standing palpitations, chest discomfort, shortness of breath that is out of the norm for them, then I would at that point say, yes, you should seek medical attention, call 911, and get to the nearest emergency room. But a lot of times we can prioritize or triage with wearables. And I'm excited about this space because at the other end of the spectrum, we have to make sure we are not abusing healthcare dollars and resources. We just don't want everybody going to the ER because they feel a fluttering or butterflies.
Yeah. That's a great segue here, and so maybe you can just elaborate a little bit. What are you seeing with wearables and consumer products out there? Is it you as a physician? I know I have an Apple Watch. It gives me a single rhythm strip, an EKG. There's other consumable direct to consumer products you can buy at CVS and Walgreens and on Amazon, and some of them I'm sure produce results that vary based on the user and conditions and situations, and not all wearables and consumer products are created the same. Is it making your life easier or harder? Like, how do
I must say, I had trepidation at the advent of wearables because all, you think of is like, the inundation of, all that information. And again, we are talking to the typical layman, right? If you'll put a monitor on or you'll put something on your fingertip to check your pulse or a watch or whatever, and the signal isn't clear, and the computer is saying, may have an abnormal rhythm or may have a heart attack, that brings on a lot of anxiety for patients. So I think, we have come a long way with technology. There's so many wearables on the market that the option is vast. At first, again, the trepidation was the inundation of all the material. There's a lot of phone calls to the physician's office, a lot of false positives. Now we're seeing that that's not the case. I like the fact that patients have more autonomy. They are active participants in their care. And my biggest thing is, when I treat patients, it's a collaborative effort. I want you to know what's going on. I want you to understand. And so when I get feedback from patients, it's, hey, I look and I wore this and it tells me I had AFib for 2 hours. That's making my life easier because if we don't have something like wearables and patients are going in and out of atrial fibrillation, which is an abnormal rhythm that predisposes clot formation and eventually could cause a stroke, then we're not doing our patients much of a service. So I like the fact that patients are now taking an active participate in care approach to their care. They're becoming autonomous, and treatment has become a lot better and easier.
All right, excellent. Dr. Beto, I'm going to sort of stay on that same topic with you. There are a host of different devices out there, 1 lead, 3 lead, 6 lead, 12 lead. How do you know what to do with what to use, what's best for you? And as a consumer, taking control of your own heart health and care, whether you're at risk or you've had a prior event, um, sometimes these wearables can make you more anxious and more depressed, right? Which
Right.
exacerbates the condition that you've already been diagnosed with. But ultimately, right, if you're having a heart attack, you can't wait. You need to get help right away. And so, can you make sense of all the different types of devices and which ones are, for arrhythmias and which ones for heart attack? And
Right. Well, yeah, and just as a sidelight, you talk about anxiety invoking. We have patients, I'm sure Dr. Fraser will tell you, that bring their booklet in and you saw them 6 months ago, and they'll bring their booklet in and they'll have every blood pressure every day, 4 times a day for every 6 months. So, they're really honed in. So that's anxiety provoking on our part as well. But anyway, I watch the commercials for the different devices. Some of them, are the evening news. They're advertising on the evening news, the one device. So I don't think the public is very attuned to what a lead is. A lead is one of the stickers that they put on during the EKG. Now, each one of those leads looks at a different part of the heart. So when you go into the ER to see if you're having a heart attack, you get a 12 lead electrocardiogram. And with those 12 leads, you're sort of getting a circumferential picture of the heart and the electrical activity, that if that electrical activity looks one way, you're having a heart attack or ischemia, we know. But on the commercials, you'll see single lead EKG. Well, that's a single lead rhythm strip, not really an EKG. When I think of an EKG, I think of the 12 leads looking at all areas of the heart. And that's what we want to see. We don't want to miss an area that may be having an infarct. So, the single lead, 3, 6 lead devices are great for looking at cardiac rhythm. Okay. If you're having palpitations, you're having skip beats. These 1, 3, 6 leads are great to evaluate your rhythm. Are you dropping a beat? Are you having extra beats? When you start to talk about ischemic events, blocked artery processes, you really need to see all areas of the heart. There's the bottom wall, the lateral, the side wall, the front wall. So there's various regions of the heart that we need to see if that's one of the areas that's causing trouble.
got it.
So there's that. I think that's very important. Depending on what you're evaluating, you could
And
kind of
that's important, Dr. Beto, from my understanding, is because it's not, if you're gonna, you need to know not only is there an ischemic event occurring, but give you as a cardiologist the best idea of where in the heart it's actually occurring too, right?
right,
Is it in the left anterior descending artery? Is it in the
right.
circumflex artery feeding the lateral wall? And that's what the 12 lead does for you.
Absolutely.
Yeah.
Again, another way of risk stratifying people, right? And that's what this is all about, risk stratifying, getting an idea of what's really going on, so that we can make the best treatment decisions for people.
So we'll move down the pathway a little bit. I had a friend a few years ago who was 43 years old, vegan, CrossFitter, owned a gym, highly successful, very wealthy guy, access to the best healthcare arguably in the world here in Boston. And 2 summers ago in July, had worked up at one of the premier institutions here in Boston. I mean, we've all heard these stories, right? And I saw him right after he got worked up, and we were down on Nantucket, and I was hanging out with him, and he had quit drinking. He was a big cigar smoker, quit smoking cigars. He's like, I'm just not feeling right. I passed all the tests. I know something's wrong, so I'm just trying to continue to exercise and live clean. And unfortunately, in December, he was shoveling snow, and that crushing chest pain did come on. He hit the ER, collapsed in the ER, and they never resuscitated him. So I bring that up because I guess we hear about this happening where people are dismissed in particular, women are dismissed for their symptoms. Maybe they're not worked up the way they're appropriately supposed to be for a heart attack or any other heart condition. And so how can people advocate for themselves if you sort of you have like something's not right? I think it's heart attack. I think it's coronary related, but I'm just not getting hurt.
The testing that we do, tests like the stress testing with the nuclear studies, the CT scans, tests for occlusion that's already present, that's inhibiting blood from going down the vessel. Now, I remember 50 years ago, the first time I took my board exam in cardiology, one of the questions was, what percentage lesion, a 10, 20, 30% lesion, what percentage lesion causes an acute MI? It's the low-grade lesions. The low-grade lesions that become biologically active because of diabetes, because of hypertension, because of smoking, because of hyperlipidemia untreated. You have that environment in somebody's body, and that creates a milieu, if you will, for these minor lesions to become biologically active. The cap ruptures off of the plaque, blood clot forms, and that's a STEMI. That's an acute myocardial infarction.
Mhm.
So, it's not just the obstructive lesions that we screen for in these tests. It's getting with a good practitioner who understands this and creates a situation for a patient that puts them less at risk. Keep their A1C around 6, keep their LDL less than 100, right? Keep their systolic pressure below 130. It's all those things that are going to put these patients in a lower risk category. And
Dr.
that's what I
Fraser,
try to do every day.
yeah, that's great. And you sort of uh, don't want to take no for an answer if you just know in your heart of hearts that just something's not right. You continue to advocate for yourself. But any advice to maybe women in particular who aren't being heard when they have heart conditions, heart attacks?
Yeah, I'd like to add to what Dr. Beta said and expand a bit. The question I typically get asked is, well, yeah, we have the non-traditional symptoms, the nausea, the jaw pain, or the fatigue. And the question becomes, well, that's nebulous. That's so vague. That's so generic. You can get that by working 3 jobs, taking care of 4 kids, right? So how do you determine that that is generalized life, or is there something that's ominous that we need to pay attention to? And the answer again can be different for different people. So it depends on your comorbidities. If you're having these symptoms, comorbidities just means it depends on what other conditions you have that's going on. If you're a diabetic, if you're obese, if your cholesterol numbers are not controlled, if your blood pressure is not controlled, or you're a smoker, then those symptoms are more ominous than a 40-year-old who is just trying to do life, right? So everything is put in perspective. The interest that I have is more so women and heart disease, because you're right. Oftentimes it just can't be. You're young, or you have these symptoms, but you're still doing other things. And that's just because for women, we wear so many hats, specifically for Black women, right? There's such a disparity with not just the sexes, but Black women compared to their other counterparts. So we may have the fatigue, the nausea, the shortness of breath, but we still have to feed the kids and still have to work all these jobs so that we can get ahead. And so when we do all of that, we tend to neglect the symptoms. When we neglect the symptoms, we present later in the event. And so that's why women do so much more poorly compared to our male counterparts, is that we present much later. How to advocate? I agree with Dr. Beto. You're going to find a good practitioner that'll listen. I am also aware that sometimes when physicians talk to their patients, they're using a language that the patients don't understand. They're using medical jargon. And so it behooves us as providers to make sure that we're speaking in a language that our patients can understand, and it's quite simple. I always recommend, and now that we are post-COVID, is to take someone with you to your office visit, someone else who could be another set of ears, another set of eyes, just so someone else gets the information. For those patients who, if there's a language barrier, whether it's a different a language, yeah, if English is not their first language, certainly take someone there to help with translation if necessary, and asks questions. You're in your visit, and the physician is saying, well, your numbers are bad, your stress test is abnormal, we're going to do a heart cath. Whoa, 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 wait, what does that mean? What am I supposed to expect? What are my alternatives? Give me the risks, the benefits, and all of that. So we like an informed patient. And I think having all of that information certainly does a whole lot for understanding, and it certainly lends to better prognosis.
Excellent. So that's a great segue into sort of a wrap up of the Q&A before we move into Q&A from our audience. And so I would ask anybody that has questions, please throw them in the queue here, and we'll try to get to all of them. We had a couple of questions that were submitted to us ahead of time. So feel free to go ahead and enter your questions, and we'll answer them in the order that they've come in. But maybe before we get to the Q&A, just some last minute advice. I'd love to hear each of your perspective on if you are at risk, if you have been diagnosed with coronary artery disease, if you are at risk for a heart attack, or maybe a stroke because you've been diagnosed with AFib, or whatever it might be, something heart related, heart disease related. Any advice to the audience for managing and improving and lowering your risk, whether that be diet or exercise? Some of the obvious things, like stop smoking, which is easier said than done sometimes, but maybe any advice that you give your patients on a regular basis that you think resonates and sticks with them, that they can carry through, that's easy to implement.
Definitely, Jason. I think it's a long run. It's a life-changing endeavor if you want to make a big difference. some people, after an event, they change their lives drastically. They're totally different people. And, that's what you have to do. You have to make life changes to be successful at this. If you don't have a doctor who listens to you and answers your questions, you need to move and find somebody who does, because this is about the patient and no one else, nobody else. If I talk about a lot about the dilution of care in the United States. So many clinics and so forth are being manned by nurses. I think you need to get to somebody who has a specialty and experience in cardiovascular disease. That's just so important. I can't stress how important that is,
Yeah.
and not really rely on computer readings and things like that. It's so important. So get somebody who's going to listen to your questions and answer your questions, and fight this battle with you, and this life-changing event with you. Create the
Let's
best.
say I mean, listen, a little selfish plug here. We know it's difficult to see cardiologists. There's a shortage of cardiologists in the US, a growing shortage. And so telehealth is a great way to go as an initial visit, a conversation. Uh,
Absolutely.
People that are members of the SmartHeart community can get access to Dr. Beto and Dr. Frazier by schedule an appointment really any time of the anytime their calendar you'll have access to their calendar to see what their availability is so it fits your schedule. Just we got about 10 more minutes. Dr. Frazier, I want to hear what you have to say, maybe about some sort of final words of wisdom here on anybody that's at risk. Any recommendations that you have?
Absolutely. Um, Again, we can't stress enough the what we call modifiable risk factors that myself and Dr. Vito had alluded to, right? Knowing the numbers, knowing your blood pressures, the cholesterol, the hemoglobin A1C for diabetics. But even so, the biggest factor that I'm seeing now that is a greater risk for coronary disease is sedentary lifestyle and obesity. I mean, we're living in the Western world where it's so easy to get unhealthy food. So we have to be intentional. We have to make a concerted effort to try to maintain what we would call a cardiac prudent, healthy diet. So move 20 to 30 minutes a day, 3 to 5 days a week, whether that is just brisk walking or biking, that helps to negate um, the bad jujus or humor or bad humors for heart disease. So definitely move. I would be remiss if I did not bring up stress as a risk factor, especially in women, right? There are two entities that we see mostly in women. Some people may have heard about the broken heart syndrome, where there's a chemical release, where there is abnormal heart function, the ejection fraction or the capacity of the heart pumping out blood tends to be low. And we can take these folks to the coronary to get a coronary angiography, and they have no blockages. But that's a phenomenon that is pretty common for women, especially who've been under great stress. And then coronary vasospasm. So those are the two two ways that we can have chest discomfort that mimics heart attack. So in addition to knowing the numbers and decreasing the stress, I would say be an advocate for yourself, right? And of course your family members.
That's great. So we do have a handful of questions here. Got about 10 total. We'll try to get through all of them here. And we'll try to bang them out one by one. So the first one is with the non-traditional symptoms that Dr. Frazier mentioned, how does a woman know if the pain or the sweating, for example, could be a sign of a heart attack? Does something feel more intense?
It can. So if Sweating is not a normal thing for you. Nausea is not typically normal. A lot of times, these symptoms just don't occur in isolation. They may be associated with shortness of breath. They may be associated with fatigue or feeling dizzy, like you're going to pass out. And those are abnormal findings. And while we don't want to overburden the healthcare industry, I say we err on the safe side. Always go to get help. The worst case scenario is you go in, you get ruled out for a heart attack, and you go home, but at least we'll live to see another day. So if there's anything that feels completely out of your norm, go seek help. In our world, time is muscle. So if it's nothing, I was short of breath last week or nauseous the week before, it's nothing, that's not the attitude to take.
And telehealth is a good option these days. Should I go or should I not go as well? If you're in a remote area and you don't have access to good healthcare or specialty care. So next question for you, Dr. Beto. How do you feel about at-home tools like Cardia with a K, Kardia? Are they accurate for the most part?
Absolutely, they're accurate. But each one of these devices, like I elaborated on, each one of these devices has their niche. Okay, Cardia is not a 12 lead system. It doesn't look at all areas of the heart. It's a great rhythm strip. I think I just sent mine to Dr. Frazier a couple nights ago. What do you think about this? So, yeah, it's a great device, but there's niches for these things. If I was having a heart attack, I would never send my rhythm strip to somebody, right? I would send my 12 lead to somebody looking at all areas of my heart. I wouldn't want to know if I was just having a heart attack in one lead, right? So yeah, they're very accurate, but they're each of them have a space, a niche that they belong in.
So 12 leads for heart attack and structural damage caused by myocardial ischemia, et cetera. Rhythm, and you can detect rhythm or abnormalities with a 12 lead, but if you need
Right.
something quick and dirty and the other devices, if you don't think you're having a heart attack, are probably okay, but not
Skip beats,
comprehensive.
pausing, that kind of stuff. The single or three lead devices are fine. They're basically like your Holter monitor. And
Okay,
that's a good question. If you have a question, reach out to us. We'll guide you as to where.
good. Um, Dr. Frazier, when you're with someone who you think is having a heart attack, do you still give them aspirin? Is there something you can do to assist while you wait for help?
Yes, so aspirin is still part of the protocol. If when emergency medical services are activated, they'll do a baby aspirin that you chew. So definitely activate EMS. Do not try to take your loved one or family member in the car by yourself because you're, then subject to traffic. So activate and just make sure that they are not in a place or a position where they could harm themselves. Meaning, make sure they're laying down, they're still talking. If they're not terribly uncomfortable, just be by their side. Sometimes with myocardial infarction, there's such ischemia, meaning decreased blood flow to the heart muscle, that causes an abnormal rhythm that's life-threatening. So ventricular tachycardia, ventricular fibrillation, and those events are, oftentimes, like I said, life-threatening. So if a person loses consciousness, and you're not, well, I would hope that I would recommend that people learn BLS, if and or ACLS, but able to resuscitate outside hospital resuscitation. So aspirin, yes, to answer your question, and just make sure that you are by that person's side, such that if they lose his consciousness, you're able to assist.
Excellent. Thank you for that. There's a question here. What is the peak age range for cardiovascular events in women in the US? I don't know if that's
Well, there's not necessarily a peak age range. We just know that postmenopausal women are at a higher risk for having events compared to during childbearing age. So men and women will have about the same propensity up until women being postmenopausal, again, because of the lack of estrogen protection, we're finding more events. So just keep that in mind, postmenopausal.
okay. Um, I'll stick with you, Dr. Frazier, for this one, I think. What does it mean? What does it mean to have 6 AFib episodes in a week, based on my heart monitor? And how does, I think the question is, am I at risk for a heart attack?
I could spend 2 hours on that question. So 6 AFib episodes doesn't mean a whole lot to me. Is it six that are 2 minutes, or six that are 6 hours? Again, that would be more than a day. But oftentimes the electrical and the plumbing don't go together. So the fact that you have atrial fibrillation doesn't necessarily mean that you're at a higher risk of having a heart attack. I have, unfortunately, 20 and 30-year-olds with AFib, and structurally, their heart's normal. Their risk is just as with the general population. So it just depends on the burden of AFib, is what we call it. How long are the episodes? And if it's truly is AFib, depending on your risk factors, we would say, do you need a blood thinner or not? Do you need a medicine to control the heart rates? Do you need a medicine to help prevent these episodes from AFib? But that's sort of a loaded question. But the
Yep.
short answer is having AFib does not necessarily equate to having a heart attack.
Gotcha. Excellent. One more question here. Well, actually, I'm going to make, there's a comment which I think is worth mentioning here, just to piggyback on Dr. Frazier, that someone said, can you make a plug to get certified and learn CPR to the audience? So I think that's a great sort of public service announcement. Doesn't take a lot to get certified in CPR and learn how to use an AED. They do save lives, both of those methods, and so I think I appreciate that suggestion. And then one last question here for you, Dr. Bito. This is sort of more along the lines. We know, there's a specialty in sports cardiology that you have a particular interest in, especially from your days at WVU, and all the athletes there. And so there's a question: why are younger athletes suffering from heart conditions these days, and what can we do? Can be done better to prevent this from happening?
That's a great question. That's an age-old debate. Do we screen all these kids? So I urge whoever sent that question, and I urge you, because we don't have time right now, I urge you to look at the Italian experience. The Italian experience with Italian athletes versus US athletes. Very, very interesting. So screening with 12 lead EKG for hypertrophic myopathy, I don't think it's more prevalent now. I think we're really honed in on it a little more. We're more focused on it, especially with COVID. We have the access to media is so great. I don't think it's more prevalent, but it's the real deal. There's so many, I can guarantee you that before my kids played sports back in the day, they had baseline 12 lead EKGs and cardiac exams. And there's a lot of debate about that. Okay, but it's not just hypertrophic myopathy. It's long QT syndrome. Now I don't know how many different types. When I was in training, there were 3 types of long QT. Dr. Fraser will probably tell you exactly how many types there are now, and there are many. Wolff-Parkinson-White syndrome, all these things could be detected by an EKG, in which case you wouldn't want your kid playing sports unless appropriately evaluated.
That's great. And it's just a small plug here for SmartHeart, and the Heart Nexus team that provides cardiac care for SmartHeart members. SmartHeart is a 12 lead EKG. It's comes with a simple application that can guide you through what takes many, many months, typically for a cardiac technician to learn how to do. And it produces that full comprehensive view of the heart that's available for use in the home. You can take it, travel with it wherever you want. And then the Smart Heart members, again, get access to Dr. Beto and Dr. Frazier and all the cardiologists, a part of the Smart Heart and Heart Nexus cardiac team. So take a visit to getsmartheart.com if you get a chance. We'll make this webinar available on our website. We hope to do this next quarter as well, but I appreciate everybody's attendance today. Hopefully you found this educational, learned a little bit. If you have additional questions, again, feel free to reach out to Dr. Beto, Dr. Frazier through getsmartheart.com. I'm Jason Baudelaire. I'm the general manager for the United States, and appreciate everybody who attended today. Take care and have a great rest of the year.